male infertility. This session will be on the management of male infertility. Thank you, sir, for the wonderful session last time. In spite of having a very bad cough, you could teach continuously for 90 minutes. That shows the passion for teaching. And the audience, again, whoever has missed last time, you don't need introduction. Sir is a pioneer in microsurgery and male infertility. He is a consultant urologist at HN Reliance Foundation Hospital and Nilavati Hospital. Sir has got devised innovative procedures for microsurgical repair of obstructive azoospermia, and he has trained a lot of urologists in microsurgery and male infertility. Sir is a BC Roy awardee, and he's got many feathers in his cap. I don't want to waste my time because all of us know about the greatness of Sir and his interest in andrology and infertility. So before we start the session, I request Dr. Uttam Mite, sir, our Honorary Secretary of Urological Society of India, to give his opening remarks.
Thank you, Dr. Surya. And as a Secretary of the Urological Society of India, it's my great pleasure to welcome all of you to attend this academic webinar. And I don't think the way Surya has already introduced the speaker, and I don't think we really need to introduce no other than Dr. Rupin Shah. I have a lot of regards and respect for him. I have seen him, during surgery, and his lectures and everything is mesmerizing lectures, I am telling you. So I don't want to tell all those things, but I just want to tell as a secretary what are the facts. Last year, out of 6 subspecialty section, the maximally attended subspecialty section meeting was in Mumbai. That was on andrology. So that shows the passion for the current batch of or the current generations of urologists. Maybe there are many reasons, and so they want to practice andrology and infertility. And second thing, what I feel, we have around 613 people are passing out as DNB or MCH every year. Maybe it has gone up a little bit, but in most of the centers, I'll say that there's no dedicated andrology section. So that means there is a knowledge gap. So we need to fill up that gaps. And the best way to fill up the gap is having a faculty like Madam Sri Ahodi, Dr. Rupin Shah. And as our Surya had already told last time, it was the basics. And this time he's going to talk about the treatment part and will be focused. And I'm sure, I'm more than certain that it will be a really enriching program. With these few words, I request Dr. Surya to take over. And thank you, sir, on behalf of USI for agreeing to deliver this lecture.
Thank you. Thank you for those kind words, sir. For those of you who have missed the last program, you can log in through the e-learning platform of USI. All these sessions are recorded. You can watch at your leisure time about this evaluation of male infertility. Thank you, sir. Over to you, sir, Rupin Shah, sir, to start the session.
Thank you very much, Dr. Surya Prakash and Professor Uttam Mete, for those very warm words. It's always a pleasure. And it's wonderful to know that the USI andrology subsection was the best attended. 35 years ago, when I was deciding to specialize in andrology, I went to my seniors in those days, Dr. Ajit Phadke, Dr. Bapat, Dr. Sonavala, and they all said, Rupin, there's nothing in andrology. You can't just specialize in that. So I think in 30 years, it has really changed, and it's a pleasure to be here. So we talked about how to evaluate, and the emphasis was on practical aspects. And that's the same approach we're going to follow today. The theory is there in the books in front of you. Or if there's a varicocele, or if there is azoospermia, or if he says, Doc, I'm unable to ejaculate, what do we do practically? And that's what we're going to discuss. So the session will be in 3, or if we will start with the practical management of oligoastheno. There's questions related to varicocele, which are always asked in every meeting. Then we'll go into azoospermia, which is very often the most confusing, at the same time, the most interesting, because there are many options. And then the very interesting subject of anejaculation, if we can. If beyond that time permits, which it will not, we will then talk of specific sperm retrieval techniques. Now, before the meeting started, I got one WhatsApp message with a question, and there was one question on the chat. So I will answer those first, and then we'll go into the talk. So one question was, often during the office, Sildana very anxious. So can he do the test at home instead? So that's not directly relevant to our talk today, but since the question has been asked, office sildenafil test very, very useful in young men, not for everybody, in selected men, but some of them will be very anxious and may not respond. So if somebody fails to respond to the office sildenafil test, we can ask them to tablet at home and report to us and compare the two responses. Second question was, if they're unable to collect semen in the clinic, is it okay to collect at home? Yes, they can collect at home. They can use coitus interruptus. We just need to ensure that there is no spillage. So when they bring the sample, ask them, did you collect everything? Secondly, tell them not to refrigerate. They have to keep it at body temperature. So keep it in the shirt pocket. Give it to the lab within 30 to 40 minutes and inform the lab that it was collected 20, 30, 40 minutes ago. So that is taken into account. And finally, and this is an interesting question, the person asked that you mentioned that morphology as low as 4% doesn't matter. So at what point should we cross over and do techniques like micro-TSA? And the reason why this question is interesting is because micro-TSA is not a treatment for poor morphology. If there's poor morphology in the semen, in the TSA sample. Micro-TSA is a procedure for azoospermia, not for poor morphology. And one other question which was asked in the chat just before we started, that should we always do mapping before a micro-TSA? There are two kinds of mapping. There's a diagnostic mapping propagated by Paul Turek, where before doing a sperm retrieval, he aspirates an FNAC from various locations in the testes, puts that on a slide and checks for sperm. He uses that to guide a future TSA. A lot of us feel that that is actually a harmful procedure because sometimes that can damage the testes. Diagnostic testicular mapping. There's also something called mapping, which is in fact going to be one of my lectures at the Androcon meeting at Hyderabad in May, where we do at the time of the actual IVF process. So the smart mapping is a procedure where the tissue is not put on a slide and given to a pathologist. Rather, it is taken and sent in media to the IVF lab to check for sperm. And that is a useful technique because on many occasions, we will get enough sperm by mapping and we don't need to cut open the testes. But that whole subject of testicular sperm retrieval is quite a advanced topic. And I think we may not discuss that today. We will start with the basics, and I'm going to start with oligoastheno, because that is indeed the commonest situation that people will face in the lab. So as always, yeah, let's minimize the images and maximize the slide. So can you please confirm that you can see the slide and hear my voice?
Yes, sir. You have to
Sure.
make it full screen. Full screen.
Okay,
Make it
so
here,
this
yes.
was varicocele. Sorry, I wanted to do oligoastheno first.
We can see oligoastheno.
Yeah, and then we will move to varicocele. So
Yes, sir.
by and large, this will be the commonest problem you will encounter. You're sitting there and you've done all that we've told you to do 2 weeks ago. You've done a proper semen test. You've interpreted it correctly. You've taken a history, done an examination, and it's oligoastheno. And now you want to know what to do. Often people ask me, is there a role for gonadotropins? And that's the wrong question. The right question is, in which men with oligoastheno will hormonal therapy help? And the follow-up question would be that if hormonal therapy is indicated, which form of hormonal therapy? Or people ask that, will CoQ solve the problem, or will carnitine solve the problem? So these are the questions we're going to answer today. And the truth is that by and large, medical therapy does not help men with oligoasthenia. Sorry, there's a phone on WhatsApp which was interfering, so I just put that off. So the common question would be that what can we do? And the truth is that no medical therapy produces a dramatic improvement in oligoasthenia. So then what is the approach to oligo? It's a comprehensive approach which has to take care not just of, sorry, lost my arrow to go ahead. My forward arrow has disappeared. Yeah, got it. So when we manage oligoasthenia, it's not just about which medicine to give. It's a far more comprehensive evaluation and advice that we need to provide the patient. In other words, we want to know, is it truly oligoasthenia? And as we mentioned last time, that even if it's oligoasthenia, for this particular couple, what is their fertility potential? Because that will determine whether we will give them medical therapy or we will move them directly to ART. If there is scope for specific therapy, which therapy will help? What is the role for varicocele? And we'll have a whole talk on that. And then the big question everybody has, will hormone therapy help? And if not hormone therapy, then which empirical medical therapy is good? So just a reminder that as per the latest edition, the fifth and the sixth, a count of 15 to 16 million per ml, or a total count, which is concentration into volume, of about 40 million would be considered so-called normal, motility of about 40% progressive, which is both rapid progressive and progressive, and 4% normal morphology. However, this is merely the fifth percentile of a fertile population. So very important to bear in mind that men with counts, motility, morphology less than this may also achieve pregnancy, and that most men who are fertile actually have count, motility, morphology much better than this. And that correlates with time to pregnancy. So this was a very interesting study. What they looked at is that in couples who achieve a pregnancy, how long did they have to try for pregnancy before they succeeded? And how did that correlate with count, motility, and other parameters? And even though we said that a count of 15 million per ml is normal, what the study found is that as the count kept on increasing from 15 to 20 to 30 to 46 million, the time to pregnancy shortened. In other words, as the count increased beyond the so-called normal, the fertility potential increased. After 46 million, it kind of plateaued. The same thing with progressive motility. Though we say 40% is normal, as the progressive motility increased to 50 and 60%, the time to pregnancy shortened. In other words, we don't have to rigidly stick to the so-called norm. If somebody has a count of 15 million, 40% motility, but has a large varicocele and is not achieving a pregnancy, we may still correct the varicocele to move him from the 5th percentile to the 50th percentile. Same time, if somebody has a count motility less than the 5th percentile, but the trying time is short, we may not rush them into therapy. So that's a very important concept when you're managing oligoasthenia. And that is to remember that semen analysis is useful, but it is only a rough indicator of fertility potential. And there are many studies, like in this study, for example, which is a very important study. It showed that in the first few years of semen analysis did not predict which couple would get pregnant. And that is important in terms of your practical management of oligoasthenia. You have a 25-year-old couple married since 6 months, trying for a pregnancy, nothing has happened, they're sitting in front of you. They don't need advanced reproductive intervention. Varicocele doesn't need treatment. They need mild placebo therapy because they've not tried long enough. And even if the sperm count is 5 million or 10 million, there's a good chance that they may achieve pregnancy. This is another study that showed that almost 1/3 of men had an overlap when you looked at fertile versus infertile couples, and again indicating that there is no clear cutoff. This was a very important study which took men who had failed one attempt at IVF-ICSI and were waiting before the next cycle. And almost 6%, not a large number, but still 6% of men whose count and motility were very, very low, less than 1 million, achieved a spontaneous pregnancy. And in fact, it was a joke in our IVF clinics that during COVID, a lot of couples who had been booked for IVF but couldn't go ahead actually got pregnant because they were at home having sex more frequently. How does into practical management? This is a slide that I showed you last time, that the duration of infertility, very important, and of course the age of the couple. So if the duration of infertility is short, even if sperm quality is very poor, there's a good chance of pregnancy. If duration of infertility is long, then even if the sperm count is very good, probably there is some defect in sperm function. And therefore, when we are going to help and advise a couple with oligoastheno in our clinic, we will look not only at semen analysis, but also how long have they been trying. They've been married 4 years, but they may have started trying only since the last 6 months. How old is the couple, especially the wife? The strongest predictor of fertility is the female age, and we see that often in secondary infertility. Couple has been married 8 years, and the first year of marriage, wife got pregnant naturally. Sperm count at that time was 5 million. Now, 8 years later, they're trying for the second child. Sperm count is still 5 million. She's not getting pregnant. The semen has not changed. What has changed is the wife's age and therefore her fertility potential, and everything, the management and the prognosis changes just because of that. So the female age and the presence of any other female factor, bad mucus, cervical hostility, immunological factors, all of those would have an impact. So in terms of practical advice, it translates into these two case scenarios. To the left and to the right are two men with identical semen reports. But the couple to short trying time, have had nominal medical therapy, there's a good chance still conceive naturally, and the treatment we would give for their oligoastheno will be antioxidants, multivitamins, maybe coenzyme, basically buying time to give nature a chance to achieve a pregnancy. Is a couple with the same semen parameters, but the wife is 34, 35, they've tried already several therapies, their file is quite thick. Just because they have come to you for the first time doesn't mean you give them another 6 months of therapy. No, this couple has a very poor chance of natural conception and they need to be guided to IVF-ICSI immediately. So this is in fact the key to managing oligoastheno, understanding fertility potential as a totality for this couple. And in fact, that is what has been highlighted in the 6th edition of the WHO manual, which we discussed in great detail in our talk last time. Then we pointed out last time that when you're looking at oligoastheno, you need to know whether there are reversible and irreversible factors. So these are reversible factors. Clinical varicocele, not a Doppler varicocele, and we'll talk about that. In our country, evidence of chronic epididymitis, chronic funiculitis due to filariasis or STDs, treatable causes, and sometimes with sometimes chronic fungal infection or chronic heat exposure, and correcting the true pyospermia, and we spoke about that at great length in our last meeting. And then systemic illness, general health, etc., all of them very important. Many couples who are obese, who are smoking, not sleeping well, they will have dramatic improvements if their lifestyle changes. Vegetables, salads, cut down on sugar, sweets, sleep adequately, exercise, and more. medicine that may actually improve the semen parameters. Nowadays, very important, if your patient looks good and strong and muscular, inquire about the use of testosterone. More and more gyms, more and more trainers are giving young men testosterone to help them bulk up, and that is often the reason for a fall in semen parameters. So if you see low FSH, low LH, high testosterone, high level of suspicion that this man has been taking exogenous testosterone. And then, of course, if there's an occupational exposure to heat or chemicals or toxins, all of those are important reversible causes. Equally important, especially when you're managing oligoasthenos. So there's a man in front of you or me, 2 million sperm count, 10% motility, history of bilateral orchiopexy at the age of 6. I would say this man is lucky to have that 1 million. I do not expect any of my medical therapy to help him further. I would tell him immediately go ahead and proceed for IVF ICSI, or count of 2 million and a YQ deletion. We spoke about that, a YQC deletion. These men, we know that over time they will progress to azoospermia. We will not waste time. We will tell them you have a genetic cause of your oligoastheno. You're lucky you have sperm. Freeze a couple of samples and proceed for IVF ICSI. So understanding both reversible causes which you can treat and buy time, irreversible causes where you should not waste time, very important in planning therapy. Now, specific medical therapy, we have this entity called functional hypogonadotropic hypogonadism. So let's distinguish between true hypogonadotropic hypogonadism. Those are men with very low FSH, very low LH, very low testosterone. Maybe from birth, congenital, or maybe acquired. The management of true hypogonadotropic hypogonadism is a 45-minute lecture. I'm not going to touch upon it because I don't want to simplify it. It's a complex topic and must be understood as a complex topic. However, there's also functional hypo. What do we mean by that? FSH-LH are normal but low normal, and testosterone is also on the low normal side. Those are patients where we need to help sometimes with basic. In our country, sometimes thickened epididymis, adherent epididymis, thickened cord. I will treat them with antifilural, anti-inflammatory, and sometimes they may have a very good improvement. Accessory gland infection, if present, proven as we have discussed, true pyospermia, a culture that is positive with all the precautions, antibiotics can definitely improve the semen quality in those men. If anti-sperm antibodies are tested, and we discussed that at length also, then sometimes low-dose steroids may help, but it's controversial. So these are correctable causes. Now, varicocele, I'm going to come to later on. That's a separate talk. So let's talk of this functional hypogonadotropic hypogonadism, which links to the question I'm also asked that, should I give HCG? Will it help this patient? Should I give FSH because I've read somewhere? Or what is the role of clomiphene or tamoxifen or anastrozole? So the first question is, should you be treating a man with oligoastheno with hormones? And for that, you look at the total testosterone. If the testosterone is more than 400 or 500, that means this testis is already adequately. Gonadotropins will not serve a purpose. Some people use 600 as a cutoff, but generally speaking, over 400 is reasonable. And in that case, no hormone therapy is indicated. If the testosterone is less than 400, or you may less than 300, then you have to look at FSH, LH, and estradiol. And inhibin, but we need not go into that. Prolactin is actually very useful, but if the testosterone is low, you can look at prolactin if the FSH, LH are also low, because a rare differential of low FSH, LH and testosterone could be hyperprolactinemia. But essentially, if testosterone is low, we want to look at FSH, LH. And so now we can have a number of situations. High testosterone, end of the story, no hormone therapy. Low testosterone, and FSH, LH are inappropriate, normal, low normal. Because if they've expected the LH to go up and usually the FSH to go up, but if they haven't gone up, then it may mean that this pituitary or hypothalamus is functionally deficient. And maybe if we raise the FSH and L through a variety of agents, then the testes will get more stimulated, the testosterone will, the inhibin will go up, and the sperm production will go up. So that answers the first question. Should we give hormonal stimulation? What hormonal stimulation? So if FSH, LH, testosterone are all low, the simplest, least expensive, and highly effective therapy is clomiphene. Many regimens are available. Give for 25 days, stop for 5 days, give alternate day, give 50 milligram alternate day, give 100 milligram alternate day. What I usually do is I will start with clomiphene, 25 milligrams daily, and somewhere after a month, I will look at testosterone, FSH, LH again. If they reduce the dose to alternate day, if they reach the limit of normal, I will continue the same dose. If they haven't gone up sufficiently, milligrams daily, and if 50 milligrams doesn't work as retested after a month, then I will give gonadotropin. Can you give gonadotropins right away? You can, but that's far more expensive and far more inconvenient for the patient. And in the majority, clomiphene will achieve the desired goal, which is getting testosterone to above 600, getting FSH-LH at the upper range of normal. Second scenario, testosterone is low, FSH-LH are also low normal, but the estradiol is significantly elevated. So typically, testosterone in nanogram per deciliter divided by estradiol in picogram per ml should be more than 10. Average testosterone, if you take 450 as 25 or 30, 450 divided by 30 is 15. But if the testosterone is low, say testosterone is 300, but estradiol is 50, which often happens in obese men, 300 divided by 50 is only 6. So in that case, instead of clomiphene, I would use an aromatase inhibitor. Typically anastrozole, occasionally letrozole. The dose could be 1 milligram daily, which is often used, but in actual practice, we have found 1 milligram alternate day of anastrozole tends to be enough. Again, you'll start with 1 milligram alternate day, the testosterone, estradiol, FSH, LH after a month and adjust the dose. Sometimes twice a week is enough. Sometimes we will combine anastrozole with clomiphene. That little playing around can be done based on the actual levels that we reach as we monitor. Then we can have a scenario where testosterone is low, LH is also low, which is not appropriate, but LH is high, which indicates some level of spermatogenic failure. Sometimes in these men, by raising the intratesticular testosterone, we can improve the sperm production even though FSH is high. So here, instead of clomiphene, this is where I would give LH in the form of HCG, which can be given 5,000 every 5 days or 2,000 thrice a week. Varying regimens, again, monitor the testosterone after 4 weeks and adjust the dose as required. When testosterone goes up in response to HCG, sometimes due to feedback, FSH comes down. So you need to monitor FSH when you're giving HCG. And if FSH starts dropping, often you may need to add clomiphene to prevent the feedback suppression of FSH. Then you may have the situation where testosterone is low, but both FSH and LH are above normal. This is a case of primary testicular failure. The testes is already being stimulated adequately with FSH and LH, and it is still not responding because it's testicular failure, and here hormone therapy is unlikely to help. So that is how you decide when to use hormone therapy and which one to use. Is there a role for FSH? So there are occasional cases, that slide I've missed here, where LH is high, but FSH is low and testosterone is mid-range. So if there's an isolated FSH deficiency, we may give FSH 75 units to 150 units thrice a week. And sometimes when we give LH and FSH goes down, we may combine FSH and LH. And that is something we often do when we are treating non-obstructive azoospermia, not so much in cases of oligoasthenia. So that was hormone therapy. Ideally, I would want to take questions here because often there are doubts, but unfortunately that is not possible. But you can write to me later. Now, if hormone therapy is not indicated, is there any specific medical therapy? So actually, varicocele repair is one option, and we'll discuss that in detail in the next talk. But what about other medical therapies? What is the magic therapy? Is it coenzyme? Is it carnitine? Is it astaxanthin? It's any one of these large number of drugs. We've already talked of the hormone modulators, but what about the others? Enzymes, cell activators, herbal drugs. The truth is that if you look into literature, there'll be studies for everything. There'll be studies that show that zinc help, selenium help, CoQ help, carnitine help, and there'll be studies that showed that they didn't help. So if you look at the systematic reviews or the Cochrane review, which pools all the data together, there is some evidence help to some extent, but the level of evidence is quite poor. So you need to know that you will give these drugs, but without any of success. So there is a small improvement in the odds ratio of pregnancy. So which one should you give? We don't know. The Cochrane study could not identify any specific individual agent which is better than the others. There are theoretical reasons for suggesting you should give a combination because different antioxidants work at different levels, achieving different impacts. Some will stabilize the cellular membrane, some will act on the mitochondria, some will act on the acrosome. So given that some drugs seem to act sometimes, how do we go about treating these patients? So understanding that it may help or it may not help, know that we are giving these drugs primarily because if you tell the couple, don't worry, go try for 1 year and come back, they'll just go to the next andrologist and get a prescription from him. One couple trying only since 6 months, 1 year, we will spend 3 months, 6 months, even 1 year, giving them all kinds of medical therapy, hoping that the medical therapy will help, but also knowing in our heart that honestly speaking, we're just waiting for a spontaneous pregnancy, which is quite possible when the couple is young. On the other hand, if it's an older couple, maybe more than 10 years of infertility, or they've crossed 32 or 33, or there's a lot of social pressure, there we know that there's no point really trying medication. So we may tell them that take this medicine, but while you're taking it, don't waste time. Simultaneously explore the option of IUI or IVF, depending on the sperm quality. So this is what I mentioned that each of the drugs act at different levels, some acting on the DNA, some acting on the membrane, some acting on the mitochondria, and therefore having a combination better option. What I've also found treating patients from a poorer class, perhaps because they're nutritionally deficient, simple, inexpensive multivitamins without the expense of coenzyme Q10 or carnitine, which can cost than 100 rupees a day, simple multivitamins sometimes produce dramatic results in a lower socioeconomic class of patients, possibly due to nutritional deficiency. In those who can afford it, you give the combination of coenzyme and selenium and astaxanthin and all the things that there are about 100 different preparations from different, none very obviously superior to the other. So the true principle is understanding that it probably may not help much, so we should not do harm. So therefore, definitely do not give injectable testosterone. Somebody with low testosterone, I should have told you this in the previous section, low testosterone, low FSH-LH, low testosterone, high FSH-LH, do not give injectable testosterone. do not give testosterone gel. You may give oral testosterone because that is very mild. That will not have a negative effect. But if you give testosterone gel, that will suppress what little spermatogenesis is present, and the man will become azoospermic. So do not do any harm, which means no testosterone. Don't waste too much money if he's a poor patient. And depending on the age, you may buy time, or you may decide you should not waste too much time at all. So that was medical therapy. Now, if medical therapy doesn't work, should you refer the patient for IUI? And it's important to realize that IUI, intrauterine insemination, which means the patient give a semen sample, the gynec will extract the best motile sperm and inject in the wife. IUI as a treatment for pure male factor infertility, where there's nothing wrong with the wife, is only to natural intercourse. So the pregnancy rate is only about 8% to 10% per cycle, which means 9 out of 10 patients will fail. And even the cumulative pregnancy rate is only 15 to 25%. So you may do IUI provided you have at least 1 million actively motile sperm after doing the harvest, which also means that if the count is very low or motility is very low, then it's a waste of time and money. And often patients and the gynec will think, TK count is only 2 million, motility percent, but IUI will cost only 20, 30,000. So let's try that before we go for IVF. But it's not going to work. That 20,000 is wasted. So if you know that the IUI will not work, don't send the patient for IUI. Let accumulate the money and instead go in for IVF, which will offer a better chance of success as compared to IUI, especially for fertility. Never forget adoption. What happens is when a couple goes to an IVF center, the IVF center only wants, but you're in a unique position where you can advise them that, see, you've been trying for 10 years, you've tried the medicine, maybe you had a varicocele surgery, you've done one IVF, none have worked. You could do IVF again, but donor insemination or adoption are both very good options. And want to tell them that for them to move on. So this was the management of oligoasthenia, which is something that we see in the clinic every day. And linked to that, of course, is the question of varicocele management. So now let's move on to varicocele. Where has that disappeared to? Thought it was right there. It's vanished. I'd opened 4 talks. I can't find them now. So I may have to stop sharing and open my folder again.
Okay, sir.
Any questions have come up on the chat box while I'm opening my folders?
And
No, sir, no questions.
No.
No questions? Sorry, I may have to log out and log back.
Okay, sir.
Okay, are we seeing varicocele?
Yes, sir. Yes. Yeah.
So everyone knows the theory. What is a varicocele? Why it happens, the nutcracker and all those theories. I'm not covering the theory, that's obvious. I want to answer the practical questions which I'm asked in every meeting. So if the AUA guidelines which somehow have disappeared from here, But the AUA guidelines very clearly state that an infertile couple with abnormal semen parameters and a clinical varicocele can be advised varicocele surgery. And yet there are huge doubts. The first basic doubt is that is varicocele really the cause of male infertility? So if you see a patient varicocele oligoastheno, what are the chances the patient will improve? What improves? Count, motility, both, morphology. Then does the grade matter in predicting outcome? Should every patient with oligoastheno be referred for an ultrasound to look for a varicocele? Or if so, what is the true role of an ultrasound? Does hormone assay predict who will improve or not improve? Does DNA fragmentation impact our decision to operate a varicocele? Is there any role for medical treatment? If you decide to operate, should you do one side or both sides? Which method is best? The question everybody asks me, should you deliver the testes and tie the gubernacular veins? So all these are questions which we will try and answer in the next half an hour. Adolescent, I may skip because that's not related to infertility, but all these are truly questions. So the very first question, and for many trigger-happy surgeons, they will wonder, why are you asking this question? Of course, if there's a varicocele, and of course, there have been studies like this. This was a controlled study, 40 men, 20 observed, and the pregnancy rate was much, much higher in the operated group. However, there are also studies like this, which was a prize-winning paper at the American Society of Reproductive Medicine, where surgery versus no surgery, the pregnancy rates were virtually identical. And in fact, the first 4 Cochrane reviews found that varicose. It was only the last review that came up, 212, and now there is one more in 2022, concluded that yes, varicocele surgery does improve the odds of pregnancy, though the evidence is still not very strong. Of course, there have been many other meta-analysis now, all suggesting that varicocele surgery will improve the odds of pregnancy. But as you can see here, it's not a dramatic increase in the sense that if you operate 6 men, then you've increased 1 pregnancy, but not everybody would need surgery. This was another meta-analysis that showed that varicocele will improve sperm parameters, will lower sperm DNA, but there is inconclusive evidence that the spontaneous pregnancy rates increase. Now, this is one of my favorite studies because it actually gives you practice when to operate a varicocele. It was a large group, 137 men who had surgery and a larger group who chose no surgery. And in the first year, pregnancy rates equal in both groups, whether the varicocele is operated or not operated. However, if you looked at a subpopulation of men who were infertile for more than 2 years, then the pregnancy rate was much higher after the varicocele surgery. So what does this tell us? The same thing that we spoke about in the oligoastheno group, that even though there is a varicocele, even though is low, if the couple is young and you give them enough time, many of them will achieve a pregnancy despite the oligo. But if, however, time has passed, they have not achieved a pregnancy, then correcting the varicocele will likely improve the fertility potential and give them a better chance of pregnancy. So the clinical interpretation of this would be that just because a man has a varicocele, you don't have to rush into surgery. You can certainly give the couple some time, 3 months, 6 months, and if they don't succeed, then proceed for surgery. Often I get patients where the surgeon has told them, this is a semi-emergency, get operated immediately or your sperm count will become 0. That is utter nonsense. The decline in sperm count with varicocele is very gradual over time. And if the varicocele is responsible, it will be reversible after the varicocele surgery. So to answer the question, is varicocele surgery effective? Yes, but not in all men. There'll be a significant number of men where you will operate the varicocele and parameters may not improve. There'll be some men where parameters will improve, but they may not achieve pregnancy. And there'll be some men whom you've not operated and they will still achieve pregnancy. So what does this translate into in terms of practical advice? Don't rush into surgery. I will diagnose the varicocele at the very first visit. I'll tell the patient, you have a varicocele, this is what it does. You have the option of having it operated immediately, or you can try medicine for a few months, 3 months, 6 months, and if it doesn't help, then we will operate. A few men will say, Doc, operate, but the vast majority are quite grateful and appreciative of the fact that they are not rushed into surgery, and they'll come back in 3 months, and some of them will have had a pregnancy, and some will then go in for surgery. Now, which semen parameters affected? Different papers claim different things. Some will say count, some will say motility, some will say the varicocele, when it has an impact, affects testicular function as a whole. So count, motility, morphology all go down. And if there is improvement, everything improves. On the other hand, if there's an isolated defect, count is very good, but only motility is poor, or count and motility are good, but only morphology is poor, that is usually not due to a varicocele. There is some other factor at play, and in those cases, I'm far more cautious about advising varicocele surgery. So what's your take-home message? That if count is excellent and it's only isolated poor motility, be quite cautious before you advise surgery. And an isolated territory, of course, we discussed last time that nowadays teratozoospermia does not have any significance. And certainly of a count of 8, motility 70% and 2% normal, don't operate his varicocele. The varicocele is not the cause of the teratoma, and operating will not help. Now, does grading matter? And there are several studies now showing that a larger varicocele, a grade 3, or I even have a grade 4, when it's visible, will have a greater likelihood of producing improvement as compared to a grade 1, which is just an early varicocele. Therefore, grading helps in determining outcome and prognosis. So personally, I have this grading should help you in your clinical decision making. 0 means that I have no suspicion and that patient will not be subjected to a Doppler or an ultrasound. And I will talk about that further. Grade 1 is where it's equivocal. And there a Doppler ultrasound helps me because some grade 1s will have a good amount of reflux and may need surgery. And some grade 1s will have very minimal reflux and may not be advised surgery. Grade 2 is definite varicosity. And depending on the reflux, we would decide surgery. Grade 3 is visible and grade 4 is the first MBBS student can diagnose the varicocele. So it matters to me. Similarly, the reflux on Doppler. It matters to me whether there is reflux even when the patient is just standing or breathing quietly versus when there is reflux only when he's blowing very hard. If he's blowing very hard and only then there is reflux, that very significant. On the other hand, if there's reflux, even when you put the probe, constantly blood flowing down, that is physiologically more likely to be a significant varicocele, and that is the one I would like to treat. The role of ultrasound. So this is the clear-cut guideline, which hasn't changed in all these years. This was an old one, I think 10 years ago, but it's the same recommendation. Only palpable varicoceles should be corrected, which means, therefore, that if it's gray, meaning no clinical varicocele, you should not be sending the patient for ultrasound to look for a varicocele. And I see this again and again. Oligoastino on examination normal, refer for ultrasound. There's no justification. If clinically you don't suspect a varicocele and you're able to examine the patient properly, you don't need the ultrasound. You need the ultrasound if it's a tight scrotum, you can't examine properly, or you think there's a varicocele but you're not sure, there you may use it for differentiation. Or if there's an obvious left varicocele and you want to know what is happening on the right side. So this is a very important practical take-home message, because this is an error I see again and again. The uroandrologist sees a patient, doesn't know what to do, and therefore sends for an ultrasound not indicated. So we will use it, as I said, to confirm a diagnosis or for a differential diagnosis or to assess the degree of reflux. As I said, more the reflux, more likely is that varicocele to be significant, and more likely is the patient to improve after varicocele correction. So I personally prefer to do my own Doppler studies, because the radiologist will often report that doesn't match fine. He will just say varicocele present grade 2, grade 3, but I want to know how much reflux. How does he reflux? Only on breathing, only on Valsalva, even on standing. So this would be my recommendation. Don't do an ultrasound if the patient is normal. Do it when indicated, and preferably start doing it yourself. Now, what about other tests? Hormone profile, like for any oligoacid, as we discussed in our last talk, count less than 10 million, look at the hormones. Varicocele is known this, and if the hormones are abnormal, one of the medical therapies while you are waiting to do varicocele surgery can be clomiphene if FSH, LH, testosterone are on the lower side. Again, sperm DNA fragmentation. Many studies have shown that correcting a varicocele, a clinical varicocele, can reduce the sperm DNA fragmentation by not too much, roughly by about 3 to 7%. So if somebody has a borderline sperm DNA fragmentation, 35 or 40, and has a large varicocele, then the justification in correcting that varicocele in the hope of lowering the DNA fragmentation, apart from improving the sperm count and motility. So if somebody has a normal semen count and a large varicocele, and they've been trying for a couple of years and there's no pregnancy, there I would look at sperm DNA fragmentation. And if the sperm DNA fragmentation is elevated, this becomes a possible indication for even though semen parameters are normal. Not a solid indication, but something that we may consider in some cases. So, is there a role for management, or does everybody need to be operated? Younger couples, we don't rush them into surgery. And if they're not rushing into surgery, then certainly during that time we can give them medical management. And I've seen at least 1 in 4 couples with a varicocele while on medical management showing improvement. So what medical management? That's based on the pathophysiology of varicocele. Varicocele impacts the HPT axis, it raises reactive oxygen, and it raises local temperature. So because it affects the HPT axis, I will often treat them with clomiphene. Because it increases reactive oxygen, I will give them antioxidants, and I will ask them to do scrotal cooling. And a reasonable number of patients do improve. There are many studies, won't spend messages that diagnose the varicocele and often trial of medical therapy, as I've shown, and warn the patient that you have the varicocele, you may improve with medicine, but there's a reasonable chance that you won't. In that case, we will operate, but certainly it's not an emergency. And if the varicocele is not operated, they achieve a pregnancy, they don't want more kids, then that varicocele can be left alone. Now, a few questions. So who will benefit? Clinically palpable, important. We spoke about that. They've had an infertility, meaning they've tried long enough. The female partner should be potentially fertile. If she is a tubal block, then there's no point correcting the varicocele. They might as well do IVF right away. And the AUS says at least one semen parameter abnormal. I don't agree with that. I feel that all semen parameters should be abnormal. Who will not benefit? Even more important, subclinical varicocele, meaning clinically normal, only ultrasound detected the varicocele, surgery not indicated. As I mentioned, I believe isolated sperm defects should not be operated, though I know many of other colleagues who will operate. And generally speaking, parameters are normal, not low normal, but high normal, near the 50th percentile, and the patient has a varicocele. That varicocele is coincidental and probably does not need surgery. Both sides. There are multiple scenarios. If there's a bilateral clinical varicocele, there's no question you should operate both sides. If there's a left seal and right side doubtful clinical, but there is significant reflux, I operate both sides, but I know many colleagues who will only operate the left side. In my experience, if there's a left clinical varicocele, and significant reflux on the right side, even though the varicocele is not palpable. Most of the times I find fairly large veins, and that's why I tend to operate bilaterally. If there's a large left clinical varicocele, no varicocele on the right, no reflux on the right, then operate only the left side. Now, which technique? You can do the old technique, which is the Palomar technique, which is high approach. You can go transinguinal. You can do laparoscopy. You can go subinguinal. Today, the gold standard is considered subinguinal microsurgical varicocelectomy. Now, why microsurgical? So if you look at this picture very carefully, you can see the spermatic vein, which is very large, labeled with an arrow. Identifying that vein is not a problem. But to the left, you can see the testicular artery and one vein. They're closely bound together. And often, in fact, typically there'll be two veins and the artery in between them. And to separate the artery from these two veins so that you can tie the veins and preserve the artery will require some degree of magnification and microsurgical instruments. If you go subinguinal, there are very often two veins, two arteries and more veins, so the need for magnification is even greater. If you're transinguinal, then the artery is usually one, and you can get away with less magnification. But I think in every case, some degree of magnification, at least loops if you're going transinguinal, and certainly the microscope if you're going subinguinal is required. We do every surgery with the microscope and with an intraoperative Doppler to reconfirm the artery. And with the Doppler, very often, at least at the subinguinal level, we will find two arteries because somewhere at that level, the main artery tends to branch. What about laparoscopy? Well, if you've been doing it and it works well and you're doing it, but in general, the consensus is that laparoscopy is actually more invasive because it's entering the peritoneal cavity and the incidence of recurrence is higher and the instruments are relatively cruder, so you might damage the artery. We don't generally recommend that. Most studies have shown that microsurgery will give you the best cure rate, the lowest recurrence rate, and the lowest complication rate. So this is a well-known table that basically repeats the same. Embolization, very common in Europe and UK and many of those countries. So it's a valid option. The problem with embolization is sometimes I've seen two patients. Sometimes there can be significant inflammation in the vein after embolization, which can actually increase pain, especially if the varicocele is being treated for test. And on the right side, there is technical failure in about 15% of cases to enter and embolize. So therefore, if embolization is routine in your center, you can continue doing it. We prefer it only for recurrent varicoceles. Otherwise, microsurgery is the preferred choice. Should you preserve the artery? Yes, of course you should, though there are some studies showing that usually doesn't matter. So which approach should you use? Basically, do what you do best. If you are not using an operating microscope, don't go subinguinal just because I told you it's the best approach. Do whatever works in your hands, but always 3 months or 4 months after surgery, do a Doppler to check that you've preserved the artery and that there is no reflux. If your quality control tells you that, yes, what you're achieving is good, continue doing that. But if you are progressing as an, then your goal eventually should be develop the skill to do a good subinguinal microsurgical varicocelectomy. Should you tie the gubernacular veins? Actual answer is no. The reason why everybody asks about it is that the chapter in Campbell was written by Mark Goldstein from Cornell. And Goldstein used to ligate gubernacular veins. So in his chapter, he wrote about that. But in a global survey and in individual papers, the consensus is that you don't need to tie gubernacular veins. You don't have to deliver the testes unless it's a recurrent varicocele or there's a huge amount of bulk in the scrotum, where to reduce that bulk, you may want to deliver the testes and excise some of those veins. Now, who will improve? Not everybody. You need to counsel the patient. 1 in 3 men probably will not benefit from surgery. The general evidence, if you go through literature, is that men with varicoceles more likely to show improvement. Men with bigger size testes more likely to show improvement. And in terms of pregnancy rates, men with mild oligoastheno more likely to achieve pregnancy as compared to men with oligoastheno. Was a study by one of my DNB students, and they looked at men with counts more than 10 million, that's mild, 5 to 10 million, that's moderate, and less than 5 million. And you can see that there's a good pregnancy rate after varicocele surgery. 2 out of 3 and 10 million to start with had improvement and achieved a pregnancy. But equally important, even when there's a million, 5 million, 1 in 3 still achieved a pregnancy. So not everybody, but a 30% pregnancy rate is almost as good as an IVF cycle. So therefore, even if a man is severe oligo but a large varicocele, it is worth recommending varicocele, telling them that you have a 1 in 3 chance of achieving success. But if you do, it's a natural pregnancy. And if you don't, then you can proceed for IVF. Do hormone levels predict outcome? Mild elevation in FSH does not rule out improvement. Very high FSH is a bad sign. Testicular biopsy is not indicated to predict outcome. It doesn't help. Testicular size, to some extent, yes, very small varicocele, less likely to improve. So there were dynamic tests done in the past, but the results have been inconsistent and we don't do it anymore. So this was what I just told you, the best in mild to moderate oligo, but it need not rule out severe oligo. Larger varicoceles will do better. Finally, varicocele and azoospermia, should you operate? Now, care for a varicocele by itself, but if somebody had severe oligo to start with and has a large varicocele, then he may develop azoospermia. So the one thing you will not do is you have an azoospermic man, clinically normal, and then you refer him for a varicose, for ultrasound to look for varicocele. That is ridiculous. If you have an azoospermic man with a very large varicocele, no genetic abnormality, no other causative factor for the azoospermia, then you may consider varicocele surgery based on this meta-analysis, which shows that many of these men will have appearance of some sperm in the semen. They do not become, they will still million or 1 to 5 million. Most of them will still require IVF, but because sperm have appeared in the semen, they may not need a testing. So we'll stop at this point. There are other factors to consider, but I want to spend 20 minutes discussing azoospermia. So that was the second part. How do you manage varicocele? And now let me see if I can find my third talk, which was on azoospermia.
Sir, would you like to take 1 or 2 questions?
Okay, let's take questions. Go ahead, please. While I'm finding the talk, you can
So there's a
continue to
question,
ask the questions.
a question from Dr. Nachiket.
Yeah.
According to which parameter after varicocele repair is most important for fertility in OATS? Number, motility, or I think you've
So
covered
in
all
my
the
experience, as I said, all three improve.
all three. Yes, sir.
All three.
Yeah. Question from Dr. Chandramohan Godala. What is the treatment for filarial or bacterial funiculitis and duration of treatment?
So I would give a combination of antifilial, that means diethylcarbamazine, that's hetrazane or banoside, 400 milligram thrice a day for 15 to 17 days, in combination with doxycycline 100 milligram twice a day for 10 days, followed by a course of anti-inflammatory. Very often that will be a low dose of prednisolone 5 milligram thrice a day for 5 days, twice a day 5 days, once a day 5 days.
Okay, thank you. There's a question in the chat box from Dr. Sagar. He has given a case scenario. OAT is 12 million, 10% motility, 2 ml volume. Hormone is FSH is elevated. Testo normal LH13 is asking how to explain high FSH LH levels.
So FSH, LH are elevated, testosterone is normal or low normal. This is obviously a case of testicular failure. Giving hormones will not help. Antioxidants probably won't make a very big difference. If the couple is young, give them some time to achieve a pregnancy despite the low sperm count. So during that time, you can give any antioxidant. If the couple is older, ask them to proceed for IVF-ICSI.
Okay. Sir, I have a question. Then in your practice, what is the average number of veins you ligate when you do a subinguinal varicocele?
So
Ligate?
actually, one of the DNB students was again doing a study, but they never got around to publishing it. The lower you go down, the more will be the veins. So when you ask me how many veins, you have to ask me at what level I operate. So when you go subinguinal, typically there'll be one very large vein, there'll be two or three moderately large veins, and there'll be one or two leash of veins surrounding the artery. So we will wind up ligating maybe 7 to 8 veins on an average.
Does it
But if you
correlate with the
go
success? Like number
if you
of
go
veins ligated?
transinguinal, then the number of veins will be less.
Yeah. No, in subinguinal, the number of veins ligated does it correlate with the improvement in this semen analysis?
No, it correlates with the size of the varicocele.
Okay.
And because size can correlate with improvement, yes, but it's not that more veins mean veins probably meant a larger varicocele.
Yeah. Okay. Okay, sir.
Okay, so now we'll move on to the last left, which will be approach to azoospermia. I just opened it. Where did it disappear to? Ah, here it is. No, it's there, but it's not appearing when I am clicking on it.
Yeah. Yes, sir. You can see it.
Got it? Okay. So this is one of the most interesting areas in infertility for an andrologist because there's more active stuff to do. And since we have 20 minutes, I'll skip some of the cases which I was going to show you and instead move directly into the main talk. Now, again, this is going to be a practical talk. Patients sitting in front of you with azoospermia, how do you manage? There are actually three case scenarios. One where you see the patient and it's obvious testicular failure, what do you do? One where it looks like it is obstructive, and what could you do? And one where you're not sure. So why do we need to make this distinction? In the past, azoospermia is very easy. Whatever you did, you wound up eventually using donor insemination. But today, maybe half the men with azoospermia have a chance of fathering their own child. So what has changed? One, of course, is that we now have microsurgical vasoepididymal anastomosis that allows us, with a fair degree of accuracy, still only 50% success, but that's not bad, to bypass obstructive azoospermia. So that gives fresh hope for men. And there's the newer technique of VA, which is not difficult. And this technique, even my residents at the end of 3 years are able to do. So any andrologist interested in microsurgery should be able to do this technique. The big thing, of course, is the advent of intracytoplasmic sperm injection that allows us to take a single sperm from the testes, from the epididymis, inject it into the egg and achieve a viable pregnancy. So that changes everything. For men with obstructive azoospermia, it allows us to achieve a pregnancy, and obstructive azoospermia, it can allow us to achieve a pregnancy. Now, in the past, we used to think in black and white terms. We said either there's testicular failure, which means there are no sperm in the testes, or testes is filled with sperm. The third group. This third group is non-obstructive, so there is no blockage, but there's still azoospermia. However, in the testes. So if there's sperm in the testes, why is he azoospermic? Because we now recognize that there is a minimum number of sperm that need to be produced in the testes before these sperm come out in the semen. So roughly 30 to 40% of non-obstructive, that means with non-obstructive azoospermia, may still have focal areas of sperm production. And recovering these sperm would allow them to achieve a pregnancy. So if you look at this testicular histopathology, you can see hyaline, hyaline, hyaline everywhere. But right at the bottom of the slide, you can see one beautiful tubule with a lumen with all the layers of spermatogenesis. So this man probably has a small test, has an FSH more than twice normal. The testicular histology was reported as complete atrophy, but tucked away is an occasional tubule, and this man could father his own child. Now, if few sperm present in the testes, sometimes they may be scattered throughout the testes, or sometimes they may be very focal. If they're scattered throughout the testes, then a simple TSA, TISA, needle biopsy may recover those sperm. But if they're localized to a few areas in the testes, then you cut open the testes and inspect it with a microscope and do a micro TSA to be able to find these sperm. So this is the implication, and we'll talk about that as we go along. But just to remind you that a man with testicular failure will have sperm. It depends on the histology. Sertoli cell syndrome, the poorest prognosis, only about 10 men with Sertoli syndrome will still have sperm in the testes. Men with atrophy actually do better. I would say about 30% of those men, we can still find sperm. With maturation arrest, it's about 30%. With hypospermatogenesis, it's about 80% in good sperm. So it varies, but on an average, it's about 40%. So an important message in testicular failure, sperm may be present, but it may not be distributed throughout. It may be very heterogeneous, and therefore one biopsy may not tell you what is happening. And that is why the traditional testicular biopsy, where you took one piece, has its predictive value. And even FNAC not very useful because it may miss these sperm. Also, more and more we are recognizing genetic causes. We know about YQ deletions. We know about chromosomal problems like Klinefelter. But now that whole exome screening is becoming widespread, we are identifying more and more single gene defects as causes of azoospermia. We're still understanding them. We don't understand them entirely, but in 2 to 5 years, I expect that we will probably have a whole gene map. And at least in half the cases of azoospermia, we'll be able to point out that this is the genetic defect because of which he has azoospermia. And these are the chances of finding or not finding sperm in the context of this genetic defect. So with this basic background, now let's talk about how to manage azoospermia. So man in your clinic, semen sample showing azoospermia. As we spoke about last time, ensure that that sample has been spun into a pellet and an extended sperm search has been done to rule out cryptozoospermia. Because if even a few sperm are found after an extensive search, that is no longer azoospermia. The diagnosis and the management algorithm completely change. Secondly, rule out temporary azoospermia. This is important. Every once in a while, patient referred by the gynec, I have azoospermia. How long have you been married? 4 years. Do you have other semen reports? Yes. Where are they? No. This last report. I tell him, come back with your file. We see the old reports. He had sperm. So now we know that this man has sperm. Temporarily, he has azoospermia, maybe because of illness or fever, or somebody gave him testosterone, and we expect that we will get sperm again in future. And of course, confirm that it was a proper ejaculation. We're not going to have time to discuss anejaculation today, but some men have difficulty ejaculating, and they don't give a semen sample, they give only urethral secretions, and that is then reported as azoospermia. So now you've got a proper semen sample, properly collected. It is azoospermia. The next thing you do is look at the volume. If the volume and fructose is absent, either this man has vase aplasia or he has an ejaculatory duct obstruction. Because the semen volume is low, very often the lab will say QNS, quantity not sufficient to test for fructose. But the irony is that it is only when that fructose is most important. So as I told you in the last talk, ask your lab to use the modified Sullivanov method so that even with 0.1 ml of semen, they will be able to check for fructose. Because if you have azoospermia, volume less than 1 ml, and fructose is absent, then you can reach a clinical diagnosis. Examine the patient again carefully and try and feel the vase. Try, if you think you're feeling the vase, try and bring it to under the skin as if you want to clamp it for a vasectomy. If it is not a vase and if it's just fibrous tissue, it will disappear as you try and bring it superficially. So if you cannot feel the vase, or if you're doubtful, or if it disappears, that is of congenital bilateral absence of the vas deferens. If, on the other hand, you can feel the vas clearly, that is a case of ejaculatory duct obstruction. If you, then what do you do? I wonder why this. Basically, this slide should have asked that do you need to do an exploration to confirm the diagnosis? And the answer is no. CBAVD is a clinical diagnosis. Do you need to do an ultrasound to confirm the diagnosis? No. If your lab has tested for fructose properly and your clinical examination is good, you do not need. Do you need to do a biopsy to prove spermatogenesis? The answer is no. In CBAVD, normal. So if the diagnosis is CBAVD, your therapeutic options are sperm aspiration and IVF-ICSI. Can you aspirate sperm and do IUI? Yes, but the pregnancy rate is very low, 3 to 5%. So the only time you would do IUI with epididymal sperm is if the patient absolutely cannot afford IUI for donor insemination. Have I had a pregnancy? Yes, only once. But otherwise, we would normally recommend IVF-ICSI, where since these couples are young, usually the pregnancy rate is very high. How do you usually from the epididymis by a PISA, percutaneous epididymal sperm aspiration? The American textbooks will recommend MISA. We never do it. We feel that is an overkill, not required. And sometimes epididymis is very atretic. You may not get sperm by PISA. In that case, we do a simple needle TSA, which means within 18 gauge scalp pin, we will do a testicular biopsy, and that will give enough sperm for the purpose, which has the same pregnancy rate as a PISA. Now, if the vase is palpable, then the diagnosis is ejaculatory duct obstruction, and the next step is not a vasogram, it is a transrectal ultrasound. The vasogram which you see is done only at the time of the reconstructive surgery, not as a separate procedure. What is important in ejaculatory duct obstruction is to recognize that there are two types of blockage. This is a cystic block. There's a large congenital midline utricular cyst, which is compressing the seminal vesicles. You can see on the ultrasound dilated SV. You can see on the vasogram dilated cyst. Simple Turid, and this patient will be fine. But you can also have this kind of an ejaculatory duct block, where on the transrectal ultrasound there is no dilatation. The only clue that something is wrong is calcification seen in the seminal vesicle. And if you try and do a vasogram, as you can see here, look at the blue arrow, you can see the convoluted vase. You do not see the seminal vesicle, you do not see the ejaculatory duct, because all of that is completely fibrosed. So it's possible to have an ejaculatory duct obstruction, and the transrectal ultrasound may look completely normal. And this is a case of fibrous ejaculatory duct obstruction. Typically happens after genitourinary tuberculosis, not uncommon in our practice. And here you cannot do a resection. The only treatment will be sperm aspiration efficacy. The other slides were just a reminder that transrectal can be very subjective. So you have to be very careful while doing the truss. Very often you may need to verify the truss findings with an MRI to distinguish between a fibrous block versus a cystic block. So this was azoospermia with fructose and a palpable vase. What about azoospermia with a normal semen volume and fructose present? Rarely you can be looking at hypogonadotropic hypogonadism, but usually those men may have no ejaculate at all, and their management is completely different. Primarily, we are looking at a distinction between testicular failure versus obstruction. We want to know if it is obstructive, where is the obstruction? Is it suitable for reconstruction? Is there a genetic cause? And if we are doing surgery, what surgery? If we are retrieving sperm, what is the best method of retrieval? If we suspect it is primary testicular failure, is there anything reversible? Would hormone therapy or any other therapy help? What is the likelihood of retrieving sperm? What method will we require to do? And what genetic study should we do for this case? So keeping that in mind, how do we evaluate these patients? We evaluate the patient through history. Very important. History, as we saw last time, that would indicate obstruction, like hydrocele surgery, or history that would indicate testicular failure, like undescended testes, or mumps orchitis. We look at the physical findings, the size of the testes, consistency of the testes, the turgidity of the epididymis. And after that, we do the hormone profile. Now, very important message to bear in mind is that if FSH is normal, that doesn't mean that spermatogenesis is normal. Often I'll get a referral, Rupin referring so-and-so, azoospermia, normal FSH, diagnosis obstructive azoospermia, referred for microsurgery. Not true. Half the men, or at least 1/3 of the men with testicular failure will still have normal FSH. Because eventually FSH depends on Sertoli function. It correlates with spermatogenesis, but not in every case. If FSH is more than 1.5 times or more than twice normal, certainly you can say this is a case of testicular failure. But even when FSH is high, it does not preclude the presence of focal spermatogenesis. You could have a man with or 50 and still find 1 or 2 areas where sperm are present, and those sperm could be retrieved and IVF could be done. So this is very important because this is an area where often there is confusion in the understanding of the diagnostic relevance of FSH. Is inhibin any better? Controversial. Some studies say inhibin is more accurate than FSH. Some say not any better. So we are still looking at that. We do it in our studies, but it's not very clear. Do you need to do a diagnostic biopsy in a man with azoospermia? Nowadays, a simple diagnostic biopsy is almost never. If we do a biopsy, it will always be multiple biopsies, with one going to the pathologist, but other biopsies going to the IVF center. Vasography in the past, azoospermia referred for testicular biopsy plus vasography. We never do a vasography as an independent procedure in the evaluation of azoospermia. So having given you that backdrop, in the last 10 minutes, we'll quickly look at case scenarios. It's 8:55, so we'll finish 5 minutes late. So based on the history, examination, hormone profile, you can categorize your patients in these three groups. In some cases, you will say this seems to be obviously obstructive. Large testes, normal FSH, good testosterone, and a turgid epididymis. In that case, if you want confirmation, you may do a simple biopsy or an FNAC just to confirm sperm. But even then, send one sample to IVF lab so that they will also find sperm and freeze those sperms so that if the patient wants to do IVF later on, that is possible. In our practice, if clinically we are very sure that it is obstructive, we may directly take up the patient for exploration and a VA. Now, the big question here is that if it is obstructive and you suspect the block is in the epididymis, should you do a VEA, a vasoepididymal anastomosis, or should you aspirate sperm and do IVFX? So the advantage of VEA is that it is not a morbid procedure, delicate procedure, it's highly specialized. It can be a daycare procedure, recovery is immediate. There's no real risk to. Depending on the level of obstruction, the success rate will vary between 30 to 60%. More epididymis is damaged, lower is the success rate, and that is a very important prognostic factor. Often I will have patients coming to me from far, far away, referred for VA, and when I examine them, I find only half of the head turgid, rest is all collapsed, and I will tell that patient your success rate is going to be very low, so you're better off doing IVF ICSI. On the other hand, if there's a nice turgid head and body, that patient would definitely be a better candidate for VA. So as a clinician, try and develop a feel for the epididymis to decide whether a patient is a good candidate for VA or not. Compared to that, IVF ICSI, of course, ICSI is more complex. ICSI is placing the burden upon the wife for a problem which is with the husband. ICSI is more expensive. ICSI is faster. After VA, it can take 6 to 12 months for sperm to appear and even longer for a pregnancy over within 1 month. So if is older or they're in a hurry, then ICSI is preferable. So in other words, younger couple doesn't want to spend on IVF. Couple has a preference for natural pregnancy, you will offer a VA. Older couple, long time, they've been trying, a lot of the epididymis is damaged. In those cases, ICSI is a better option. Post-hydrocelectomy, success rates are very poor because the damage is very extensive. If there's a filarial obstruction, large hydrocele with azoospermia, even if it is obstructed, the epididymal quality is usually very poor, and we've not had good successes in those cases. If it's a tuberculous obstruction, usually the blocks are multiple and we cannot do good surgery. But in other cases, we would prefer a VA. The second patient you will see in the clinic is obvious testicular failure, meaning there might be something in the history that tells you this is testicular failure. When you examine him, it's a small testis, soft testis, and the hormone report shows FSH, LH, both well above normal, testosterone on the lower side. Here, you do not need a biopsy to tell you that this is testicular failure. It is obvious. So here you can tell the patient directly that based on your examination, based on the physical findings, we know that there is a problem with your testes. We know that there is no sperm being produced. So you have two options. Either you can go in for donor insemination, or we can try and retrieve sperm from your testes. It's a 30% chance we'll get sperm. And if we get sperm, then we can do IVF ICSI. And there we give them two options. Either we tell them first we will do the TSA, which can be a needle TSA or a micro TSA. And if we get sperm, we will freeze them and then stimulate your wife so that if there's no sperm, she doesn't need stimulation. Or we tell them that we will stimulate your wife, and the day of egg pickup is when we will retrieve your sperm. The advantage of that is that if we find sperm, we have fresh eggs ready, so the chance of success is a little better. Disadvantage is that if we don't find sperm, then your wife's stimulation is wasted unless you're willing to keep donor sperm for backup. So this is a very important discussion. This is a complex discussion. So only if you're actually working with an IVF center will this slide really make sense to you. Finally, this is a patient that many of you will see in your clinic. Normal size testes, normal epididymis, not flabby, not turgid. FSH normal, but on the higher side. You don't know, is he obstructive? Is he not obstructed? Does he have sperm? Does he not have sperm? What do you tell the patient? So here you may do a trial teaser, which means take 3-4 biopsies from one side, typically with a needle. Send one biopsy for histopathology so you reach a diagnosis. Send the other biopsies to the IVF lab so they can check viable sperm, and if they find sperm, they freeze them. If you're working in your private clinic and not with an IVF lab, you can get media from the IVF lab and transport the tissue in the media to the IVF lab. But you need to have some coordination with an IVF lab while dealing with azoospermia if you really want to do justice to the patient. And then, depending on the findings, you may find either normal spermatogenesis and reconstruction may be an option. You may find no sperm at all in any of the biopsies, in which case you may need donor insemination, or you may find very, very few sperm, in which case you know that this is a testicular failure with focal spermatogenesis, and you can take up this patient for IVF-ICSI with either the frozen sperm or with a fresh testicular sperm extraction. So this is just azoospermia is complex. Until you actually manage these patients, this will not really sink in. So in summary, it's very weird. Several of the slides are not showing the text. In summary, azoospermia, very interesting. You have to consider history, physical examination, and the hormone profile to distinguish between three groups. To do proper justice, you should have training in microsurgery. You should know various techniques of sperm retrieval, and you should work in conjunction with an IVF clinic. Simple diagnostic biopsy, not to be done. Simple FNAC, not to be done. Any biopsy should be multiple with some tissue, most of the tissue going to the IVF lab, and some tissue maybe going to the pathologist. So that was 2 hours overview of how to manage the common problems. Of course, this could be a whole one-day symposium also, but I think this gives you a general idea. So thank
Yes.
you very much.
Thank you, sir. Would you like to have one or two questions, sir? There are some questions. Question from Dr. Philip Raj Joseph. After varicocele surgery, does the fertility potential improve even when there is no improvement in counts and motility?
Can happen. Sometimes count motility doesn't change much, but the DNA fragmentation has dropped and the chance of pregnancy may go up. There are 4 interesting studies where men with oligoastheno and varicocele who are undergoing IVF were divided into 2 groups. One group where the IVF was done directly, one group where the varicocele was corrected, and then IVF was done. And the pregnancy rate was higher following IVF in the group where the varicocele was corrected, suggesting that yes, fertility potential may improve, even though semen parameters may not change very obviously.
Thank you, sir. I think that will answer the question of Dr. Chandramohan. He was asking the same question. In case of non-obstructive azoospermia planned for micro TC with clinical varicocele, is varicocele surgery beneficial? I think you've answered
So
that.
as I said, in selected cases, I operate a varicocele and non-obstructive azoospermia maybe only once a year, though I see literally 100 non-obstructive azoospermics in a year. So which should tell you that they decide to operate a varicocele should be very conservative, not done frequently, And if you're operating a varicocele with azoospermia, always remember to take a biopsy. Send one for histopath because that will give you prognosis, and one or two to the IVF lab, because if they find sperm, then they can right away proceed with IVF ICSI without having to await the outcome of the varicocele surgery.
Thank you, sir. Question from Dr. Naveen Kumar. Success rate of subinguinal versus inguinal varicocele repair. I think we have already
So
covered.
the chances of sperm improvement be equal, but most studies have shown that the recurrence rate is lower with subinguinal.
Okay, sir. There's another
But
question.
do
from
what you're best at.
Yeah. Dr. Priya, I think it's not related to management. How do you counsel a young unmarried male presenting with unilateral or bilateral scrotal pain with ultrasound showing varicocele, grade 2, grade 3 varicocele?
That's a whole different discussion.
Yes, sir.
Orcalgia and varicocele. I'll just give you one word of caution. Be very, very cautious before you attribute orcalgia to varicocele. Make sure that it's a typical pain occurring intermittently after prolonged standing on exertion. I find this very ridiculous situation. A young boy, 15 or 16, one episode of testicular pain, and he's referred for ultrasound to look for a varicocele. Has no correlation with that one episode of pain. So if a patient is sitting, even when he's lying down, when he's crossing his legs, none of those are due to a varicocele. So be very careful before you attribute pain to the varicocele. Rarely it can happen. He'll tell you, doc, whenever I play sports, I get pain, and otherwise I'm fine. In such cases, you may have to operate.
Fine, sir. Thank you, sir. That will conclude all the questions. Now we'll come to the conclusion. Thank you very much, sir. Dr.
Thank you.
Keshavamurthy, sir, President USI has joined. Sir, would you give your concluding remarks? Keshavamurthy, sir.
Thank
Yeah.
you, Dr. Upita, sir. Sorry, I got stuck up in the Bangalore traffic, so I joined 5 minutes late.
Famous
But it was
Bangalore
a
traffic.
wonderful discourse on the male infertility. Both the sessions were really good, and we have had great feedback from people about these two programs, and they will be on the e-learning platform, so all of them can watch anytime they want to. It was wonderful, and thank you very much for spending your time on both these classes.
My pleasure. Thank you. And I think this e-learning is a wonderful structure that USI has created. And I'm sure that will continue to go from strength to strength. Thank you.
Thank you, sir. Thank you so much. Thanks all the audience for joining this session. Thank you so much, sir. I think we will adjourn.
Bye.
Thank you.